Oh yeah, I forgot you have your own special PowerPoint.
Oh yeah, yeah.
I think I have an email from you still. Hold on. And I'll make sure y'all get this PowerPoint online here too, but HM1 Carroll made his own PowerPoint over this chapter.
While you're looking for that, I'm HM1 Carroll. Leave that on there. Yep, I'm HM1 Carroll. I'm an instructor over at the schoolhouse right here inside the START building for surgical technology. So got some limited experience with this stuff in Iraq and things like that. I haven't been a boots on ground kind of guy corpsman yet. So see if it happens before I get out of here. You guys up? Awesome. All right, so this is going to be down and dirty. I'm not going to have you guys out here for a long time. I've already highlighted the things that I've seen on the test over time frame. So I'm going to tell you exactly what I want you guys to take note on, and we're going to get out of here. We'll be done with my section. Excuse me. All right, so chapter 21. All right, so some general first aid rules that they highlight in the chapter is maintain breathing, stop bleeding, and prevent or treat shock. All right, so triage, what I want you to write down or take note of is that it means to sort. Seen that? You guys probably all know that, but take note of that. Okay, so we're going to talk about triage in the non-tactical triage setting. All right, so take note of these categories, right? So priority 1 is immediate, often on the triage card, red, right? So the injuries are critical. That's another term or word I want you to remember, critical, but require minimal time or equipment, okay? That's priority 1. Priority 2 is delayed, noted with the color yellow, all right? These don't require immediate care to save life or limb. If I start moving too fast, just put your hand up, say, hey, I wasn't done taking a note or something like that. All right. Moving on. Good. Okay. All right. Here we go. So we have to talk about our priority 3. All right. And remember, we're still in a non-tactical setting, so put that as your heading or something so you don't get this confused when we start talking about tactical here in a second. All right. Our priority 3 is our minor. Right. On your card, it'd be green. All right. And these are your walking wounded, minor injury folks. And then you got your priority 4, which is expectant, meaning they were probably going to die. I think you usually see something on the test, something like brain matter exposed. They have, they're breathing, but their brain matter exposed. What do you label them as? Right, these are going to be expectant. And then your priority 5 would be your dead. Right, these are black also. All right, unconscious, pulseless, breathless. Anyone have any questions on the non-tactical triage categories? Priorities.
So you might ask yourself why we care about triaging out those that are expectant or whatever else, right? Sometimes, and those that have been deployed, your delayed or stable patients can go to immediate if they're exposed to stress of seeing somebody dead, right? So usually they'll separate them from them and triage them out, because as you know, with any kind of other stress, what does stress do to us? Raises our blood pressure and our pulse, right? So if you're somebody who has a stable condition and now you're raising the blood pressure or pulse, they now can somehow fall into an immediate category and have more life-saving care, right? So that's where that triage comes into play.
All right, so we're going to jump into our tactical now. All right, so make a separate column, whatever you need to do to delineate these things. All right, and we're going to talk about our categories now. All right, so category 1 in our tactical setting is our walking wounded. Right, we're going to get these folks back to the fight as fast as possible in the tactical setting. All right, these guys can do buddy care or take care of themselves, wrap their bandage up their wound. All right, and then we have our immediate, which is categorized by red, all right, which require life-saving emergency surgery. All right, so we're talking about upper airway, or penetrating wounds, things like that, respiratory distress, tension pneumothorax, decompensated shock. All right, category 3 is delayed in tactical triage, right? So these require surgery, but the condition permits delay, right? So some examples, you got a tourniquet on, whatever, they got a broken bone, maybe they got a bleeder or something like that, but it's under control. We got a little time to take care of whatever other situations are happening on the battlefield before we need to get this person out of here to take care of them.
I'm glad you highlighted that, because that one is on the test, is what's going to confuse people and mess them up, right? Everybody sees massive external hemorrhage. What's the first thing that pops up in their head? Immediate, right? Well, if you see here, if the bleeding is under control with a tourniquet, or the patient is stable, and you're in tactical triage, what is that massive external hemorrhage going to be labeled as? Delayed, right? That's what's going to mess you up on the test. So pay attention to those situations and what the actual patient's status is.
Absolutely.
Also, I don't know if anyone else has noticed, but between the tactical and the non-tactical is listed as priority, and tactical is going as category.
Yeah, so please don't pay attention to that priority. That should be category. Again, I made these slides, so there we go. Thanks for pointing that out. But category 4, all right, is you're expecting. All right, so these people are on the way down. They're getting ready to die. All right, so what we got highlighted here is a TCCC algorithm. We're not really going to go down into that. So note, right, this is a tactical triage, right? And you have some subtle nuanced differences from other things you guys learn, like TCCC and all that stuff, right? All right, let's talk a little bit about some airway management. So some numbers. Numbers are always good to know, right? So never suction more than 15 seconds for an adult, 10 for a child, 5 for an infant, right? So 15, 10, 5, think about the age groups dropping down.
That's a test question.
Nope. Then you got your OPA, which stands for oropharyngeal airway. All right, so we don't use this on a conscious patient, right? Hopefully we all know that. And we measure that from the corner of the mouth to the ear. All right, seen that one on the test. Okay, I mean to insult anyone's intelligence, but what is our maneuvers that we use to adjust the airway so that we can see if it's open or try to get breathing going? Tilt, chin lift, and jaw thrust. Good. All right. NPA, nasopharyngeal airway. We measure that from the nose to the ear. That's the big thing I want you to take away from there. Some other side notes. Do we force it in if it's not going? What do we do? If it's not going in one, try the other. There you go. Lubrication of it. Like, what do we use to lube it up?
Surgilube.
Surgilube, if you got it. What else?
Spit.
Some of their spit, right? Not yours. How about their blood? So that's kind of up and down with that, right? They say try maybe not blood if you can avoid it, right? Because it's going to clot, and now you got something stuck in there that's clotting. So that's what they say. Try not to use it. It should have a mouth, hopefully, still there. But push comes to shove, get the thing in there, right? All right, so a combi tube. I have not seen this on the test. I actually went back and asked some of you all that took the test last go around if they heard anything about it, saw anything about it. Have you heard anything about it?
Not seen combi tube.
Right.
Crike is on there, not combi tube.
Yeah. So I kept it on here, but I was like, well, maybe one day they'll ask about it, but they haven't. But it's just another airway device. It has a couple dual lumen that allow you to put different things down there. But haven't seen anything about it, so I'm not gonna hit it. All right. So cricothyroidotomies. All right. So what are our landmarks? without going into all this extra stuff. What's our landmark to look for? Somebody give me something.
Cricoid membrane.
Thyroid cartilage. What was that? Or thyroid.
There's actually a
cartilage.
saddle in your cricoid where
Cricoid
you're supposed to make
membrane.
your incision.
Right. What's that called? That area.
Cricoid thyroid membrane.
There you go, right? So you know one, you know the other, and then you just call the membrane in between them.
Correct.
Right, good. So we got a 1.5 inch vertical incision.
That one's a test question.
Yeah, 1.5 inch vertical incision you're gonna make. All right, with your knife blade or tool of whatever sort you got, and get that tube in there. Everybody got that info? Definitely see these on the test all the time at the E5, E6 level.
So I wanted to say something too, because I know that people ask these questions on the test, right? When was the Corner Manual last updated?
2010.
Correct, right? Now, are there other emergency medicine manuals that are newer that are produced?
Yes.
Okay, so if there's something, let's just say for instance, the vertical incision length. Say in the Corner Manual says 1.5 inch, but an emergency war surgery manual publishes something that now says, that published in 2023 that says 1 inch, right? Which number do you think you're going by? The 1 inch, right? So I say that because there's numbers that will contradict each other, so you got to pay attention to the most latest version of what it's talking about and the subject of how the question's asked to know what measurements you're using, right? I say that because your nosocomial infections is also mentioned two or three different ways in your instructions you're studying. One says 48 hours, one says 48 to 72. Right? So you need to know what editions you're reading as you're trying to study this information.
All right, and there's a depiction of the process happening. All right, so needle decompression. So let's talk about some of the things we see, right? So what's our landmarks? It's up there on the on the slide. What are we aiming for?
Second and third intercostal space. Midclavicular line.
Let you read real quick. My bad. I thought I was gonna spit that one out. All right. Yeah. Right. So midclavicular, second and third intercostal space, right? Our bore of our needle, right, is 3.25 inches long, and it's 14 gauge. That's what they're looking for. So, do we go on top or on the bottom of the rib?
Well,
There you go. Why is that?
vascularity.
Nerves, blood vessels, all that stuff run around the bottom, right? Good job. Good job. Everyone got that info written down? Definitely see that on the test a lot.
Anybody know the second landmark?
Fifth intercostal space.
Correct. Which honestly, and I don't know why they haven't changed it, is probably the more preferred because based off of, we'll just take me and him for instance. He has a bigger build and probably more skin to go through on there, so it might be harder to get the needle D in. Everybody's rib cage is almost about the same with the amount of issue to where it's going to be easier to get a needle D in there sometimes.
Right. And so that's the thing, right? Like he was just saying, something multiple doctoring. Right? I happen to be highlighting what's actually in the Corman Manual, chapter 21, but you have to go off of whatever all your bibs that they're talking about, right? So let's get it. Okay, let's talk about some O2. So oxygen mask, right? We're talking about the mask goes over your nose and mouth and get you up to 10 to 15 liters per minute and up to 90% oxygenation. All right, more numbers. In our nasal cannula, it's 1 to 4 liters per minute and 24 to 44% oxygenation.
Put stars next to those ones. Those ones have been on the test.
Shock. All right. What is shock? Inadequate tissue perfusion. There's 3 major categories, right? Hypovolemic, distributive, and cardiogenic, right? Hypovolemic means we don't have enough blood volume. Distributive means our blood vessels are dilated. We're not pushing the blood where we need to. And cardiogenic is the heart problem. All right. Okay, so the stages of shock. The red ones. I want you guys to know that, right? Compensated means it's non-progressive. Your body is figuring out a way to handle the situation. All right. Decompensated your BP is falling, your blood volume is dropped, and treatment sometime has recovery, right? Sometimes. All right, and then irreversible shock means exactly what it means. We ain't coming back from this type of shock unless there's a miracle.
Quick question. I'm not questioning your intelligence, but it helps make sense of all this, right? Anybody know what actual shock is? We say treat for shock, but does anybody know what shock is? Can anybody explain it?
It's the breakdown of one of the big three. So either the pump containers or the fluid.
Correct.
That's how I've always gotten.
Correct, because the key word in there on the slide before just says inadequate tissue perfusion, right? It's basically saying that there's not enough blood being pumped through the body to keep your vital organs alive, right? Our body works as a system, so if there's not enough blood pumping and one of your systems fails, your body has a fail-safe to where it tries to compensate for those failed organs, right? Well, when an organ starts working more than it's supposed to, eventually that organ fails and it goes into a system of failures, right? So our goal is to stop the bleeding so it's not ever leaving the body and putting blood back in to where that blood perfusion then pushes through and gets those vital organs going again, right? So the difference between the compensate and decompensate is, right, basically there's enough blood being pushed to all the vital organs to keep them alive, or decompensates are losing so much blood that they just can't stay stable. Does that make sense to y'all? I say that because we say terms all the time as corpsmen that we don't even know what the term means, right? So treating for shock, that's what shock is. That's what we're trying to prevent so that body doesn't go in a system of failures to where it ultimately just dies.
Stuff. All right, so more blood loss. All right, the brain can go 4 to 6 minutes without oxygen before permanent damage occurs. All right, 4 to 6 minutes without oxygen, permanent damage. And then you can die within 2 minutes from a massive hemorrhage. No, both of those. Oh yeah. Okay, an adult body, adult male has how many liters of blood? Roughly 5 to 6 liters. Okay, I took a note of that. I know I don't have it on the showing on the slide, but know that also.
2 minutes is up to 3.
Is it?
Mm-hmm. You're still supposed to get a turn to get on in less than 2 minutes, but 3 minutes is the time frame.
Correct. All right, so some of the classifications of hemorrhagic shock. 4 classes of shock, right? So you got your class 1, which is less than 7,500 milliliters. So, okay, before you guys get to taking a whole bunch of notes, right? I went back and I asked people, like, do you guys remember seeing this on the test after we taught it last year? I didn't get a lot of people saying yes, they remembered it from the last exam, but I have seen it. I've seen it in the past.
So the things they like to ask for this section, because I have seen questions on the test, is the things you need to study, right? They like to talk about the percentage and what class it's related to. So they'll say 15 to 30% of blood volume is classified as what class of shock? You're going to know that it's class 2, right? The only time I've ever seen this on the test is when it's asking about percentage and which class it's related to for blood loss.
So, take note of the red. All right, class 3 and class 4. Take note of the red, right? So class 3, 1,500 to 2,000 milliliters and 20 to 40% of blood volume, all right? And your class 4 is greater than 2,000 milliliters of blood loss, or over 40% of the blood volume. Also note in there is no radial pulse or weak carotid pulse.
The vampire.
All right, no. We're going to talk about patient assessment as it relates to the Corpsman Manual, Chapter 21, right? So you have your initial assessment, your general impression. APU, what's that stand for?
Alert, verbal, painful, unresponsive.
There you go. Good. CNC. Where's my quad zeros at? Show of hands.
Chief complaint.
Oh, dang. Nobody? We got
Chief
one?
complaint.
Chief complaint, right? There you go. Good. All right, we talked about our airway, right? We talked about how to open our airway. Our airway adjuncts are ready. Breathing. We'll note our rhythm, rate, and quality during our patient assessment, things that we're taking note of. All right, and circulation, color, and temp. Radial pulses. Children and infants, obviously things are going to be at different levels. All right, and controlling our major bleeds. All right, treatment for shocks and load and go and stay or play. All right, you got to be able to make that determination with some sort of quickness. What's an MOI?
Mechanism of injury.
Good, mechanism of injury. How about NOI? November. Say it again. That's right, nature of injury stuff. All right, so let's see who knows it. DCAT BTLS. Who's got the D?
Deformity.
Good. C.
Contusion.
A.
Abrasions.
P.
Punctures.
Somebody else. B. Somebody else. T. Tenderness. Good. L. And S. Good stuff. Good stuff. Good stuff. All right. How about sample in regard to the patient assessment acronym? Sample HX. Signs and symptoms. Good. A. Allergies. What else we got? M. Medication. Someone else. P.
Pertinent medical history.
Pertinent. Past/pertinent medical history, right? And how about L?
Last oral intake.
Good. And how about E?
E-
I'm sorry.
Events leading up to.
There you go, right? History. Good stuff. All right. There it is. If you need to write any of it down, if not, or if you need it afterwards, you can get it all to you. All right. So we'll talk about our sign system. OPQRST, right? Another acronym I would know just to help you out. So I don't know how many of you all like to get into the test and write down a bunch of little stuff on your scratch paper simply give you that opportunity. Definitely for me, these kind of things help because I'm a surg tech and I didn't do a lot of soap notes and all that stuff, so I had to write all that stuff down just to help me out. But onset, provocation, quality, radiation, severity, and time. OPQRST. I definitely would just take note of that acronym. All right.
Nitro.
Nitroglycerin administration. All right. So this is going to be used if these conditions are met, right? Chest pain, history of cardiac problems. It's administered sublingual. And if there's no relief, this is what I've seen on tests. If there's no relief after the administration of nitroglycerin, you repeat it every 5 minutes or until your systolic is 100 beats per minute. All right. So definitely note that one. 5 minutes, repeat every 5 minutes. Let's talk about anaphylactic shock, which means what? What is anaphylaxis?
Allergic reaction.
Good. All right. So definitely seen this one. All right. So the treatment for it, right, was 0.3 to 0.5. I didn't change that. It's is it micrograms? Micrograms. UG. Excuse me. Micrograms of epinephrine auto-injector. IM or SQ.
It's up to 3 times, right? Also.
After 3 times.
Isn't it up to 3 times?
Up to 3 times.
A batch remediation? Because it's the same thing for treating agents.
It's a different molar weight.
Say again?
The Epi Junior's a different composition. It's a different molar weight
Oh.
than regular EpiPen or the adult EpiPen.
Noted. Stuff. All right. Let's talk about some brain injury indicators. All right. So some of the things we look for, right? Variation in pupil sizes, failure for the pupils to constrict properly, progressive loss of strength, cerebral spinal fluid leakage from the ears. Do you give these people anything by mouth? No. All right. What's our test when we're checking for CFS leakage?
Halo test.
Halo test. Awesome. How do we do that?
Piece of gauze.
Ear.
Piece of gauze in the ear. See if it creates that halo effect. Good stuff. Good stuff. Let's talk about chest injuries real quick, real briefly. You might notice that there is some difficulty with breathing, of course. It's a chest injury without any signs of airway obstruction. So sucking chest wound is the most serious of those chest wounds we want to watch out for. Late signs of a second chest wound is tracheal deviation. All right, good. Talk a little bit about some drugs. All right, so combat carries. All right, if they're still in a fight, right? Mobic, 15 milligrams once per day. All right, I would say you kind of got to know these ones. We can send you the slides, right? If you guys don't have this particular slide, or it's probably still in the slides you guys got. Everyone got the slides? Okay.
I'm going to send them your PowerPoint, but they have another PowerPoint.
Gotcha. The other one probably has it too, but all right. So you got to kind of know the drugs, right? And it's a tough one. And for me, I'm not great with the numbers and all that, but you got to know it. All right. So know that you're gonna have your Moic 15 milligrams by mouth once per day. Tylenol 650 milligrams by mouth every 8 hours. All right. If you're able to fight. Now, if they're unable to fight, you got your oral transmucosal fentanyl citrate 800 micrograms.
It's your fentanyl lollipop.
Right, that you will tape to the thumb. You guys probably seen that stuff in CCCC training or real life. Put it in their mouth till they fall out and the thing falls out their mouth. All right, so what does a corpsman carry? All right, they're going to have morphine sulfate on them, 5 milligrams, IV or IO. All right, promethazine, 25 milligrams, and moxifloxacin, 400 milligrams by mouth.
If you give your patients the fentanyl pop, take their gun away from them.
Just take their gun away from them in general when you're taking them, because remember, most of them go unconscious. So I like to put this out, right? If somebody was just in a firefight and they go unconscious and they wake up, what is the first thing they probably are going to think that they're in right now? They're going to think they're still in the firefight and trying to grab a weapon. So the first thing when you're treating your Marines is immediately remove any way to where they can harm themselves or harm somebody else before you start providing care to them.
Quick question. So why do you administer promethazine along with morphine?
You don't.
It just says he carries that.
Oh, okay.
Oh, yeah.
One or the other.
And the moxifloxacin is going to be your antibiotic.
Which 9 out of 10 is going to be the combat go back administered by the Marines. So.
Correct.
Anyone still take note on that? Moving on. All right, so the adult dose of morphine, 10 to 20. It's not right.
So on the test, because this is where they'll word the questions, right? They want to know that you know when and when not to give medications, right? So they'll give a scenario where your casualty has respiratory depression, right? They're going to have a list of drugs that you can give them or treatments. And if you put morphine on there, you'll be wrong, right? Because what it does is if they are already in kind of respiratory distress and you're giving them that means that their breathing is going to be even slower and delayed when they're already, that's the whole point of morphine, to where they basically are going to die, if that makes sense, right? If somebody has a brain condition or their pulse is already lowered, you don't want to give something that lowers their pulse even more in that situation.
Yeah. So 10 to 20 milligrams every 4 hours at equal rate of 100 micrograms per second there. But understand that it is a respiratory depressant, just like you said, right? Don't give it to somebody with a second chest wound. Okay, broken bones. Don't attempt to reset them, right? Splint in place. That's about that. Don't do that. Pelvic fractures. So pelvic binder, right? Most of the time, all the high-speed guys that run with the Marines tell me they don't really carry them. But if you got one, once you set it, are you going to take it off?
Oh.
There you go, right? Oh. All right, and to the best of your ability, you're going to try not to move the patient, if they've got a suspected pelvic fracture on the battlefield. But of course, you're going to do what you got to do to keep everybody alive. Okay, eye injuries. So this is always a good one because there's the book, the Corpsman manual still, no, I take it back. It does say the right thing now. All right, so for eye injuries, right, this lady has a stick in her eyeball. Do we cover both eyes?
No.
Yes, no, yes,
No. No, you cover one eye.
So, Corman Manual says both, right? In chapter 21, it says, essentially, if you're in a place where it's safe to do so, you do want to cover both eyes, right? However, if you're in battlefield mode, right, one eye, and that person can see out the other eye, that other eye should be left open to see, all right? Because now they're blind. Now you have to completely carry them everywhere, right? But we all know that, if this eye is looking, it's going to try, the other eye is going to mirror what the other one's doing, right?
Not to mention, because the reason why it's one eye, right? Your eye's function is two of the same, of the normal functionality. And if you cover both and one is not able to still maintain that function, the likeliness of you being able to save that eye or the components of that eye are worse, right? So they want to make sure that your eye is still blinking on the other side and kind of still maintaining that same thing with this one, to where that's easier to save that eye in that situation, right? And for covering it up is the same reason why I talked about waking up after a gunfire, right? Somebody can also flip the fuck out with both eyes covered, looking pitch black when they wake up too, right? But deployed medicine with DHA and their newest guidance, if you go on there for there, it says cover one eye. Okay.
All right, talking about some burns, first degree. We're talking about an epidermal layer burn, right? Sunburn, something like that. All right, your second degree burn. This is where you have your epidermal blisters, molted appearance, and painful weeping. All right, roughly 2 to 3 weeks of healing time. And then your third degree burn is where we're talking about full thickness, white to black. There's no pain because nerves and things like that have been destroyed. All right, let's keep that in mind. 1, 2, and 3. All right, then you got your rules of nines. This has changed quite a bit over the time I've been in the Navy. So the best thing I'm going to tell you right now is to look at the most recent chart and see what they got. Because if I'm not mistaken, inside of, this is right from chapter 21. This might be the most up to date. I wonder about that they got. But it used to be nines. If you've seen it, I don't know how long you guys been in, but it used to be like real easy math, relatively, for it to be nines instead of them just making it tens. But 4.5, one side, stuff like that. Now you see it's 13, 2.5, 2, stuff like that. So you definitely want your little cheat card there to dial that up if you're passing that along to the provider. All right, so I believe this is the last one. It's a little comparison: heat exhaustion versus heat stroke. All right, so there's no heat exhaustion. You're going to be moist and clammy skin. Pupils may be dilated. Normal or subnormal temperatures. All right, and as opposed to heat stroke, where we have dry, hot skin. All right, I've definitely seen that. Dry skin, stuff like that on the test. Talking about heat stroke. Pupils constricted and a very high body temperature. All right. Along with that, what are some obvious things that we're going to do if somebody's going through any kind of heat pathogen?
Rapid cooling.
Rapid cooling, right? We're going to get them iced down if you have that capability to do it. Get them out of the sun. Get them out of that hot environment. IV fluids if you're in that kind of capacity to get that done.
So to make it make sense to y'all too on what is happening with heat stroke, right? Dry, hot skin. That means that your sweating is a cooling mechanism. So if you have dry, hot skin, that means in a very hot environment, it's a bad sign. It means that your cooling mechanism has failed. And your body is starting to overheat. When your body starts to overheat, your brain is starting to overheat, right? So if anything that affects your neurological symptoms are going to cause your pupils to become constricted, right? So dry, hot skin and constricted means that you're going into that heat emergency of heat stroke, right? So think of that when you guys are trying to remember and differentiate between the two.
Any questions on anything?